Good morning, everyone, and welcome to the webinar on the IHI Call 8 on a city-based approach to reducing cardiovascular mortality in Europe. My name is Nassima, and I will be moderating this webinar today. Before we start, I just want to give you some information. So the first thing is that we are recording this session, and it will be published on the IHI website. We'll also publish the presentation slide. The call will be launched shortly, and all the links and details of how to apply will be published on the IHI website and the Funding and Tenders portal. Important thing, if you want to ask questions, please use the chat function on the right corner of your screen, and we will address them at the end of the presentation. Today, we will have two presenters. So we have Calliope, who is scientific officer for this topic. She's going to start with a presentation, and we also have Franck Perrodin from Novartis, who is going to present the topic itself. So now I will hand over to Calliope.
Yes, good morning, everybody. So welcome to this webinar. So today's webinar will actually cover an introduction to the IHI program. Then the topic writer will present the topic itself. We will give you some information on the proposal submission and evaluation, and some tips for writing a successful proposal. What we will not cover are the rules and procedures, which are available on our website, as a webinar on this was already presented yesterday. So if you have questions on rules and procedures, please watch that webinar. So the Innovative Health Initiative is a public-private partnership for health and innovation between the European Union, represented by the European Commission, and Europe's life science industries, represented by our members COSIR, FPA, including Vaccines Europe, Europa Bio, and MedTech Europe. So at IHI, our goals are to translate health, research, and innovation into tangible benefits for patients and society, and ensure that Europe remains at the cutting edge of interdisciplinary, sustainable, and patient-centric research. So, health research and care increasingly involves diverse sectors. By supporting projects that bring together all these sectors, IHI aims to pave the way for a more integrated approach to healthcare. So in consequence, the IHI projects are created via open and competitive calls for proposals and bring together these cross-sectorial aspects, leveraging the contributions from the industrial partners, from the IHI industry associations that I mentioned earlier, and if relevant, the contributions from contributing partners, and of course, the public funding via the Horizon Europe program. So the IHI Strategic Research and Innovation Agenda details the areas IHI should work on and guides IHI's decisions on call topics. So at IHI, we launch both single-stage and two-stage calls. Call 8 is actually a two-stage call. So how does it work? So the industry partners align themselves from the IHI private members, align themselves around a shared challenge and decide to work together and commit resources to tackle the challenge. So they form what we call the pre-identified industry consortium, who in fact prepares the topic text. Once the topic is approved by the IHI governing board, the topic is launched in a call for proposals. There, the pre-identified industry consortium who prepared the topic text step aside, and the applicant consortia form to apply for the public funding only. These consortia normally include academics, hospitals, patient organizations, SMEs, and so on, and they work together to prepare the short proposals that must be submitted to IHI by the call submission deadline. Upon the deadline, the short proposals are evaluated by an independent panel of experts, and only the top-ranked proposal is then invited to stage 2. At stage 2, the winning proposal of stage 1 will merge with the pre-identified industry consortium from the topic stage and prepare altogether the full proposal. They will go again through a round of evaluations, which will result in a go, no-go decision to receive funding. If funding, of course, is granted, the granting phase will start. So I will now give the floor to Franck Perrodin, who will present the topic. Franck, please go ahead and let me know when to move to the next slide.
Thank you, Calliope. Good morning, everyone. It's a real pleasure and honor to be introducing this topic text and project for the IHI community. So, as you probably know, the cardiovascular mortality is one of the main burden on economies and public health budgets. Calliope, if we may go to the slide 2 directly, please. Basically, it is acknowledged that at the scale of the planet, nearly 1 trillion are spent every year on treating and managing cardiovascular diseases. And in Europe only, a publication in 2021 showed that nearly 300 million burden is caused on the economies of the EU. And when you look at the split, healthcare costs, productivity losses, and the people caring, the patients suffering from cardiovascular diseases is not minimal. So it's really a clear issue, and we anticipate this to be increasing if we don't course correct and if we don't work together in addressing the cardiovascular burden in Europe and beyond. What is important to understand as well is that within this cost, 85% of the mortality is linked to hyperlipidemia, atherosclerosis, cardiovascular diseases. So it makes hyperlipidemia one of the major issues that we need to tackle when addressing and thinking about cardiovascular diseases. If we go to the next slide. So as I said, 18 million people die annually from cardiovascular diseases, and WHO has put an ambition to reduce cardiovascular mortality by 30% by 2030. And this is valid also in Europe, where urbanization is also a major cause of concentration stress that will impact cardiovascular. And this urbanization will increase to reach probably nearly 85% of the European population living in cities by 2050. And as I said, pollution, the scarcity of green spaces, the lifestyle, the stress in an ambient urban area makes cardiovascular an even worse topic to address, for which, unfortunately, no solution has been identified, though the availability of affordable treatment. If we look at the curve of cardiovascular mortality, we see a reduction in the 90s and 2000, but lately we see a resurgence of cardiovascular issues and prevalence, in Europe, with Germany leading the group of European countries in this resurgence of cardiovascular mortality. If we go to the next one. And of course, to tackle this issue, not a single actor can resolve it. So it's very important that we think of a public-private and cross-sector collaboration. It's linked to the nature of cardiovascular challenges. We're talking about treatment inertia, we're talking about infrastructure, and in treatment inertia, nobody can say, oh, it's the cause is my neighbor, right? It's the one next door. So it's really a core responsibility between patient, between healthcare system, between healthcare practitioners, but also the industry as a supplier of solutions, not only treatment, but diagnostic or medical device technology, in order to really tackle the challenge linked to cardiovascular diseases. And working together is, we believe, the way forward in order to reconcile the fragmentation of the system and to define solutions that will be adopted, that will be beneficial and implemented. So as an industry consortium with pharma company, biotech, medical devices, we've come to this proposal, and we are suggesting that we ally forces between private and public partners to ensure that we will develop solutions in a comprehensive manner, which would be evidence-based, because we know we need to demonstrate the impact that our initiative would have. And we need to be aligned with, of course, public health needs, government future expectation, and patient outcomes. Next slide. So what is the topic about? The objective is to focus our effort on cities in identifying and creating scalable models, intervention, practices to enhance the overall efficiency and effectiveness of cardiovascular disease management. Based on existing model, and we took an example of cardio for cities, and we would like to develop pilots in up to 5 cities. We limited in the original proposal to 5 cities in order to keep it sizable, but also in order to manage the budget that would be made available for the public consortium, and I'll come back to that in a moment. What we suggest is that those pilots should propose a good coverage of and representation of different geographies and contexts in Europe, deliver scalable solution that can be expanded to other cities. And we also think that any proposal should look both at primary and secondary prevention. We understand that in order to tackle cardiovascular diseases, the prevention of the events, so the reduction of the event, but early prevention, but also the improvement of treatments after cardiovascular events such as stroke or MI or heart failure, for instance, requires everyone's inputs in order to get early detection, timely diagnosis and treatment, but also look at lifestyle changes and living environment. So it's really a holistic view we want to have. And there could be a question, and I would be happy to address that during the Q&A, but we decided to focus on cities in order to have, let's say, more reachable, more sizable environment in order to maximize our impact. And in cities, we find the relevant context, which are representative of the European Union, which means representation of population, economic diversity, gender, and access situations, which are scalable, and that could be, of course, replicated, as I said, in other cities, but also in more rural environment. Next one. So I'm not sure I want to read to all of you through the slide, but I'll just focus on the title. So what are the expected outcomes? Basically, we want to be of impact for patients and citizens, right? Identifying preventative measures, better diagnostic. We want to focus on healthcare providers by providing evidence-based guidelines on cardiovascular management, providing best practices example, and improve overall treatment and prevention of cardiovascular in European cities. Healthcare system decision makers will have also, thanks to the program, better evidence in order to make better recommendation and better decision that can be then after used in clinical practice and in society. Health technology assessment bodies, payers and regulators will definitely benefit from the outcome by having better information on real life use of cardiovascular products, cardiovascular devices and diagnostic in order to better assess the risk profile and also to make enlightened choice about the reimbursement of the coverage of drugs or medical devices that will serve population and system. So in terms of definition of cities, We have used the OECD definition that we are looking at a city of more than 50,000 inhabitants. And when it comes to partnering, of course, researcher, industry stakeholders, clinical investigators are also welcome to join the partnership. That will help future program implementation in other cities in Europe, and why not beyond. Next slide. So what do we expect to achieve, right? So the first is, of course, in order to measure outcome, we need to know our baseline. So we need to conduct gap analysis of existing CVD screening, diagnostics, but also elements of behavior such as nutrition, physical activities, and socioeconomic disparities. We want to monitor the decrease of cardiovascular burden by looking at the reduction of cardiovascular events, disability, and mortality. We want to look at clinical pathways. So how do we improve patient journey in order to get better patient outcomes? We know that from experience, cardiovascular disease patients often are, if I may use the term, cycling in the system, and that leads to inefficiencies and therefore lower patient outcomes. So what can we do together and to improve clinical pathways and management of cardiovascular patients between primary and secondary care? We want also to improve the patient flow in the healthcare system. Can we improve diagnostic early detection so the influx of sick patients would be reduced, and we enhance prevention of cardiovascular events? The standardization of performance indicator is also key to mortality. Just to take a few examples, scientific guidelines, for instance, on hyperlipidemia vary country to country. 100 milligram per deciliter, 70 milligram per deciliter, 55 milligram per deciliter, depending on the risk of the patient, is just one example I would use, where standardization would help in providing clarity and better management of patients, and help also intervention for future studies. Optimization of healthcare expenditure is clearly something we all sought for in the context of constrained budget and economy slowing down. As I said, 282 billion are spent annually in EU for cardiovascular management. I'm sure we will all agree that if this can be reduced and repurposed for treatment of either better patient outcome in cardiovascular, but also other diseases, would be welcomed by the systems and by the industry and partners at large. And we want to prioritize spending for maximum efficiencies and value in order to balance the cost of advanced intervention and their long-term benefits. Finally, last but not least, the public awareness is critical, right? We know too well that cardiovascular diseases risk is often perceived as non-substantial or in evidence, and until people face an event. So what can we do together to improve awareness? What can we do to improve diagnostic, to make routine and early screening part of the, let's say, normal management of patients, so we can reduce cardiovascular premature CV death and support preventative healthcare measures? Next slide. The second part of the list is, of course, we want to strengthen patient and citizen input into the treatment pathway. So the voice of the patient is critical, listening to how they live their disease, and also be a source of information for new guidelines and enhancements. We want to contribute to the European policy on active and healthy aging. To no surprise, Europe is aging, as most of the population worldwide, but it's particularly true as well for Europe, And we want to align with the European Commission proposal for the European health data space to implement EHDS by providing FAIR data aligned with the EHDS requirement. We want to start building a system for continual impact assessment. So measuring impact is really key to the success of this consortium, and want to provide early evidence on the impact of and effectiveness of the applied recommendation. Finally, we should not work in isolation or in silo. We want also to connect and be connected to other IHI or IMI initiative, and we want to leverage the learning and the outcomes in order to synergize and avoid duplication of resources. Next slide. So from an industry consortium, we've been able to rally the laboratories or the different companies which are listed here. So I just named them: Menarini, Novo Nordisk, Servier, Siemens Healthineers, and Huawei. And Novartis, whom I'm representing, is leading that industry consortium. Next slide. So what do we expect from the public consortium, right? We expect the design of ongoing pilots or leveraging ongoing pilots. And again, on those 5 bullet points, this is not an exhaustive and not limited to, but we wanted to give a frame. So including models, management and coordination platform, data from prospective observational studies, necessary health intervention on medical devices, diagnostic and medicine, support to the organization of meeting, workshop, conferences that will aim at the goal, achieving the goal of the initiative, and set up coordination and dissemination platform through IT system where appropriate. Finally, expertise in the field of R&D in relevant science fields, clinical development, medical and regulatory affairs, medical education, health economics, data management, and communication when we think about awareness in particular. Next slide. So as an industry consortium, we expect, we've been able to define a contribution to the amount of 15 million euro, 15, which would be done through in-kind contribution from the different industry partners that were listed on the previous slide. Of course, this is today a good estimate of the budget, but it's a good estimate of the commitment of the industry to support this initiative for the next 5 years. So it's a 6 years. So we aim to go to we aim to have this project running until 2030. This is linked to the nature of cardiovascular outcomes and the required duration to measure impact in a sizable manner. So the project is aimed to start in 2025 and run until 2030. Sorry, and I will stop here. I'll give it back to you, Calliope, to manage the second part. Thank you.
Thank you, Frank. Before we address the questions, let me take you through a few more slides very briefly. So in terms of the proposal submission and evaluation, so the proposal template has several parts. Part A with the administrative data, Part B, which is the narrative part, and the annex, which is the participant type. What we advise you to do is read very carefully the instructions in the proposal template, as addressing each of the instructions will help you in your application. The evaluation criteria are the usual criteria of excellence, impact, and implementation. Understanding the criteria will make you also understand how the proposal is then evaluated. So please make sure that these criteria are taken into consideration when preparing your proposals. And some tips for you. So please read all the call relevant material, especially the topic text that Frank presented. Of course, the proposals will be evaluated against the topic text. Form your consortia early, and please consider already the public-private partnership component. I know industry will only join at stage 2 should your consortium win the short proposal evaluation, but please already consider when preparing your proposals that industry members will join at stage 2. Ensure that all the information requested in the call text and proposal template, as I said earlier, is provided. And consider early a plan for the potential regulatory impact of the results. So, of course, to build a strong proposal, you need to find good project partners. So we have put here some links to help you in your search for partners. And you will, of course, have access to the slides online afterwards to have access to these links. So having said that, we can now go through the questions, and I'll give the floor back to Nassima.
Yeah, thank you, Calliope. I will invite our colleague, Domenico Lalli, who is legal officer, to join us for the question session. So the first question is from Rada, asking how can European cities be promoted / selected to join this call?
Sorry, can you, how the cities can be selected? Did I understand correctly?
Yeah, promoted / selected to join this call as CVD cities.
Look, we have no, I would say no recommendation nor preference in terms of cities. The only condition we put in the text was a minimum of 50,000 inhabitants in order to get first connection to OECD reference definition of a city. Second, in order to have a sizable population in order to run, I would say, the impact or the statistics and the measurement of the impact.
Thank you, Frank, for your answer. The second question is from Mikel. Are biomedical research centers and public hospitals eligible as partners?
I would assume, I'm not expert enough in IHI, but I would expect yes. Making part of a public consortium makes total sense to have hospitals based on the design and the concept that we're sharing through this topic text. It makes total sense to include or to have such partners in the consortium.
Okay, thank you. Now we have a question from Steve. It's quite a long question, so I will divide it in three sections. So it's asking, the call is asking for pilots in up to 5 cities. So his first question is, what is mean by a pilot? Why not clinical trial like RCT? This is his first question. Okay,
so let me take this one. Yeah, thank you. Thank you, Steve, for the question. Okay, through the evolution and the creation of that topic text, we had several exchanges with experts from EU, etc. It's been considered that a city is a pilot, and that's how we look at it. We put up to 5 cities in the topic text, being mindful of how much a pilot and an intervention would require in terms of funding, and looking at the 15 million that we've been able to collate as an in-kind, we believe that's a reasonable amount. So if you take 5 cities, 15 million, that's make 3 million per city divided by 5 years. That makes, if I'm not wrong, 600,000 euro per year, roughly. I don't think RCT will fall into that, unfortunately, because the cost of clinical trials are far beyond that. But at the end of the day, interventional studies, observational studies could definitely fit into that, into the project as we've designed it. But again, the term of pilot was because we only selected 5. We could not be in all countries at once. So that's the link between pilot and cities. But I would not stress too much on that one.
Okay, thank you. And his second question is, how many people do you expect in each pilot?
That's a good question. I would say to the consortium to define what would be the right size. I'm not an expert neither in interventional study nor in stats, so it's difficult for me to address that one. Sorry.
Okay. And his last question is, how can we work with Cardio4 cities? Can we do pilots with the ecosystem? And in which countries is Cardio4 cities active?
Okay. So cardiosophocytes I know better. So definitely yes, cardiosophocytes can be a model, can be let's say a way to look at it. Cardiosophocytes has run pilots in Rio, Ulaanbaatar, Dakar, Kigali, Melbourne, and I know they're also looking at running some workshop in some European cities. So that's definitely a model that we know is operational and that can be leveraged as part of the pilot. Yes.
Thank you. Now we have a question from Daniel. What kind of industry partners are eligible and what are the requirements?
This is for us.
Yeah, that's more for you.
Yes. So Domenico is yeah.
Yes, strictly from a legal point of view, beneficiary must be registered in the territory of a new member state or an associated country. So each industry must be respond to these requirements. But we also have an additional requirement. So SMEs and mid-cap are eligible because the only eligible entities are those which have an annual less than 500,000 million.
We have audio
Okay,
issues.
there's a problem.
I hope that you hear Domenico's reply, and then we can move to the next question.
Okay, so just to, if you can find the eligibility requirement for SMEs and mid-cap in our frequently asked questions, if you want to find something.
Thank you, Domenico. Now the next question is from Amelia. I understand that the aim of the pilot is to evaluate the proposed intervention to improve CVD prevention in cities. Do you expect the intervention themselves to be developed as part of this project, or should there already be some evidence?
I would say, as a general principle, we expect to have an impact on cardiovascular. So we want to measure before and after. So I would favor project, or we would favor a project, sorry, that will look at impacting cardiovascular and generate measurable impact on cardiovascular mortality.
Thank you for your reply. And the next one is from Gudul. I see much overlap with urban design consideration. Could this be a part of the pilot?
Apologies for my ignorance, but urban design collaboration is an IHI topic as well, or European?
So the person is stating in brackets, overheating of the city, lack of green, etc.
Yeah, in my presentation, there was an element related to the living environment and the stress generator. So yes, definitely, but let's not lose focus from the cardiovascular impact. So we need to connect both in order to make it, I would say, sensible and logical within the context of this project.
Thank you. And now we have Steve asking, what do you expect in a pilot? Can this be prevention plus treatment? How big can a pilot be?
Yes and yes. How big? Up to 15 million is the maximum that we can afford, thanks to the European Commission and IHI. Then the IHI board will decide on the final project selection. But yes for prevention, yes for treatment.
Perfect, thank you, Frank. And now we have Alona asking, can it be more than one consortium?
Maybe I can answer that. So it's each consortia form to apply to the call. So you will prepare one consortium, one proposal, and then one of those consortia will be selected to go to stage 2. So of course, I hope this answers the question. So it's one consortium per proposal, and each proposal should address the elements of the topic text.
Thank you, Calliope. And now we have Paolo asking if he understood right. So he said, I guess that you are also interested to the socio-economic aspect and the different cultural diversity in order to effectively modulate the prevention lifestyle messages, and communication. So he's asking if he's right.
Yes, that's correct. And we need to contemplate that, definitely. I agree.
Perfect. I think that the
Can
audience,
I clarify
Maybe
that point?
there's something.
if you can clarify,
Yes,
because we have to with Domenico,
Okay, it's
unfortunately.
okay now?
I think so.
Okay. So just to clarify, SMEs are eligible for funding, but there is a particularity in the call, in the two-stage call of.
Sorry, can you repeat? The sound is very bad. Only when Domenico speaks. Sorry, Domenico.
I don't know what is happening. Sorry.
It's just like we have a small voice behind after you speak. Sorry.
So I will try and cover what Domenico was saying, and SMEs are eligible to request funding. There is, of course, a threshold in there, which is the 500 million turnover.
Yes.
So if you are above, not eligible, below, eligible.
They can find this in
And you can find this information in the frequently asked questions on our website. So and then you can apply as an SME. And in terms of the countries that we see questions about how many countries can be in the consortium. Of course, we have some minimum criteria for the eligibility. So at least entities from 3 member states should participate, or associated countries, correct, Domenico? So at least 3, but then there is no maximum. But of course, you have to take into consideration the budget, what is requested from the call, and so on, to justify your choice. Even a big consortium does not necessarily mean a good. It's not necessarily a good or bad indicator. It's all about how you justify it.
Yes.
So let's ask Frank.
So we have another question from Paolo. Regarding CVD, do you refer to mainly ASCVD or also the other form of CVD? Can the ASCVD-CVD be extended to the cardiometabolic diseases, focusing also on comorbidity?
Look, it's a very good question, Paolo. It's a continuum of diseases. So to the first part of the question, yes, we're looking at CV mortality, bearing in mind that ASCVD is the main cause of mortality, but we can't limit, and we don't want to limit to ASCVD as part of the project. When linking to cardiometabolic, it's definitely a consideration. I would just stress, how can we make sure we don't dilute, right, the impact and the measurement, but it's almost impossible to disconnect cardiovascular diseases from comorbidity, such as diabetes, obesity, and things like that. So an approach that would be more holistic, but focusing on an impact on cardiovascular mortality would make sense.
Thank you, Frank. And now we have an echo here. And now we have a question from Veronice. Are you expecting different preventive treatment strategies to be implemented in the 5 pilot cities, or can it be the same implemented in different cities?
It's a good question. The industry is not here to, let's say, recommend or to design, but I would say from where I sit, I would believe that 5 times the same exercise or the same pilot or the same project would be of better representativity for EU in an aspiration to scale it up afterwards. But that's not limiting. Okay,
thank you. And now we have Marina asking, in the IHI website, the topic text has a new budget and also 2 new pre-identified industry consortium. Is this correct, or is the one Frank told?
So couple of things. So the topics are not yet launched. So what is in the topic in the IHI website are the draft topics for IHI Call 8. Of course, so maybe to clarify, the budget right now is 15 million from the pre-identified industry consortium as in kind, and 15 million of EU funding. And the partners are the ones indicated by Frank.
Thank you, Calliope. I don't see any other new question. So meanwhile, can I ask you to use the chat box to send your question? Also, I would like to promote the other topic webinar that we will have. So we will have 2 webinars on Thursday, one in the morning, one in the afternoon, and a last one on Friday on the 3 other topics for Call 8. I also take advantage to ask you to use the platform to find partners and to start building your consortia. So you can schedule meetings. You just have to go to the B2Match platform and search for participant in the participant tab to search for partners and asking to schedule a meeting with them. And if you have any question, don't hesitate to write to us. If it's related to the B2Match platform on the events mailbox, and if it's related to the call topic on the applicant mailbox. I see that we have a new question. So from Burak, if cardiovascular disease is a competing risk, for instance, with cancer and rheumatologic diseases in terms of mortality, would the cardiovascular mortality rate associated with different diseases, not just cardiologic comorbidities, as in the previous question, be included within the scope of this project? We cannot hear you, Frank.
Sorry, no, I was saying, wow, it's a good question. My, I would say, answer would be, as long as we can measure an impact on cardiovascular mortality, there's no intent to limit. But I would really call for simplicity and for, let's say, pragmatism in the design of the proposal.
Thank you. Now we have Agatha asking, when is the call going to be launched? So we don't have any specific dates so far, but we know that it will be launched definitely in June. So that's why we say shortly, but stay tuned. I would encourage you to follow us on social media to know exactly when the call will be launched. And the next question is from San. How can we already partner with Cardio4Cities in stage 1?
Maybe I can comment on that, Frank. So Cardio4Cities is not necessarily a partner. It's more about, as the way it is put in the topic text, is presenting a sort of model. So, of course, it comes from an initiative of Novartis, if I'm correct, Frank. And
yeah, Novartis Foundation.
Yeah, and partnering with Novartis will only be possible at stage 2, when the winning proposal of stage 1 merges with stage 2, and you should not be working with Novartis at stage 1. So this is something to remember. Yeah. You can already read about it, see how it works, and put effort into seeing how this model can be replicated. But working with Novartis at stage 1 is not possible. I don't know, Frank, if you want to add something.
No, that's correct.
If I can add something, according to the rule, it is strictly forbidden to approach the members of the pre-identified consortium.
Yeah.
I sincerely apologize. I need to disconnect. I've got another meeting that started 3 minutes ago, so very sorry.
We know. No, thank you very much for your questions.
If there is any additional question, I'm happy to provide back an answer or a comment on that.
Okay. Thank you very much, Frank.
Thank you so much. Thank you
very much.
Thank you all.
We will start addressing the next question if we can. Mm-hmm. Otherwise, we will forward them to Frank.
Yes, we will.
Yeah, because here I can see that San has sent a question, and we have also Paolo sending us another question. So what I'll do, we will close now the webinar. So thank you, Calliope and Domenico, for your participation and presentation. I will all see you, I hope, on Thursday morning for next webinar, and I wish you good luck for your proposal. Thank you very much. Bye-bye.